the first question, Dr. Williams, is how did you become interested in this space flight health research field, and what are you studying?
I fell into it. In 2010, actually in 2012, I had been put in touch with NASA, or actually NASA had been put in touch with me because they had discovered a new problem with the astronauts. And it was January of that year, and I was on a telephone conference call, because we didn't have Zoom at the time. I knew as soon as they were done that the problem was likely related to the intracranial pressure, which is the pressure of the spinal fluid inside the brain and the head, and that they were going to need research to understand was that the case or not. And I invested my time in further conference calls with them. Eventually, NASA put out a request for applications for research, and I received my first of those in 2012, and then have been conducting research with NASA ever since then. The problem that they're concerned about, that I'm interested in, is currently called space-associated neuroocular syndrome. And what that means is that some astronauts who come back from long-term space flight appear to have some swelling of the optic nerve at the back of the eye. And that's similar to a disorder that we see in patients here on Earth. And the concern is that it could cause restriction of vision, or in extreme cases, loss of vision. So the question is whether that is related to the pressure of spinal fluid in the astronauts as it is in patients on Earth. In order to measure the spinal fluid pressure, if we think about patients on Earth, there's only a few ways that that can be done. The most common is a procedure called a spinal tap, or a lumbar puncture, and that involves using local anesthesia on a person's back, and then passing a thin needle until the tip of the needle is in the spinal fluid space of the low back, and you can measure the height of fluid in a column that's attached to that, and there are normal values for that. It turns out that about 8 astronauts have had those lumbar punctures. 3 of them have had elevated pressure, but NASA's concern was that they didn't know whether astronauts were predisposed to have elevated spinal fluid pressure, or whether that was simply a consequence of space flight. So understanding the pressure of the spinal fluid before and after space flight is what my research involves.
Thank you. What is the gist of your research findings to date?
We have looked at several issues. The first is that we tried to see whether there were non-invasive ways to measure the spinal fluid pressure. And there are several techniques that are available and have been tried in clinical use. They depend on the relationship between actually the inner ear and the spinal fluid pressure. And I went to Umeå, Sweden, in northern Sweden, where colleagues of mine have a lab where, for testing patients for other purposes, we actually changed the pressure of the spinal fluid, and we used one of these non-invasive methods to see if it could detect that change. And the answer is that it could, but only if the pressure was significantly elevated. And I've often said that's kind of like the check engine light on your car. You know something is wrong, but you'd like to know sooner whether there are those changes. And NASA has had other researchers using different non-invasive techniques, and they are all more or less in that same category. They suggest that pressure may be elevated, but it's not certain. But we also did some research with a colleague of mine, Ben Levine, at UT Southwest in Dallas, to actually find out in humans, is zero gravity in fact influencing spinal fluid pressure? And there's a way that you can do that with young adults who may have had a reservoir into the spinal fluid placed when they were children, often for certain types of pediatric cancers. they don't take that reservoir out, so it's possible under sterile conditions to place a very thin needle into that. And if you then take them into one of the aircrafts that perform what they call parabolic flights, so they go up and down, and during that down phase, they have about 15 seconds of zero gravity. And we measured the spinal fluid pressure during those cycles and found out that whereas everybody thought spinal fluid pressure was going up in microgravity, it was actually dropping in microgravity. And so now we have a conflict between the short-term microgravity experiments that suggest that spinal fluid pressure is dropping and the appearance of the eyes in the astronauts and some of the lumbar punctures in the non-invasive tests that suggest that the spinal fluid pressure is increased. So we still have to resolve what's going on with that. My long-term project with NASA has been to recruit astronauts who will be going up on long-duration space flight to perform a lumbar puncture before their flight and after their flight to see is there difference in the pressure. And we actually do that a little bit differently from a standard spinal tap. A standard spinal tap involves having a patient on their side, and then we do the local anesthesia and we place the needle in there. But we want long-term recording in astronauts. So we use a technique where we have a bed that actually has a hatch in the back. And once the needle is in place, we can connect tubing to essentially an intensive care monitor and record that pressure continuously. And that allows us to see how that changes over time and with other certain maneuvers that we have the astronaut perform. So we want to be able to look at that in astronauts before space flight and after space flight. It's hard to convince astronauts to participate in that research. They're like all other research participants. They have to give their permission to participate in it. And NASA astronauts are actually asked to participate in lots of different clinical research. So the other thing that they take into account is whether the time necessary for our work fits into the schedule of the other research. So it's been slow going in accumulating that information.
So what more do we need to learn, and do you envision that health issues could be managed in space with more research?
There's a lot more that needs to be done. The ideal would be to have a way to measure the spinal fluid pressure directly in an astronaut or another space flyer during space flight. And the only ways that that can be done are to put something into the head. And that's something that I have looked into. I know that there's some other research that's in the early stages that's being looked into, and that's sponsored by the Translational Research Institute for Space Health, which is called TRISH. Because until we can measure the spinal fluid pressure in space for a long period of time, we really won't understand whether those short-term changes that we see have any bearing on what happens once an astronaut has been in space for 120, 180, 360 days. It's known that the longer an astronaut is in space, the more likely they are to develop this syndrome, to develop the swelling of the optic nerve. And the concern is that if you want to go to Mars, which is a long-term goal that NASA has, if all you were to do is to fly to Mars and come back, it would take 500 days, which is the longest space flight that anybody would ever have done. If you want to stay, then the flight is even longer than that. The other issues related to getting to Mars, besides the microgravity, are that you have to take everything necessary to live, to have water and oxygen, to anticipate medical care needs and so forth. So there's lots of other health issues that astronauts are at risk for during spaceflight or long-duration spaceflight, in addition to SANS, which is the disorder that I'm interested in.
So is it possible to predict which individuals would be at highest risk for the condition that you're studying?
NASA has been trying to answer this question. And in fact, every year NASA has a research conference with all of the health investigators who are involved. That happens to be this week. It's a remote meeting. And at one of the presentations yesterday, the showed data from a model that's trying to predict who may be at risk, but it's still in the early stages. So the real answer is right now, we don't know. The concern, of course, is whether that information would be used to say, well, this astronaut can go, but this astronaut can't, or would it be used to say, well, this is an astronaut who's going to need some extra attention or what we call countermeasures to prevent this from happening. The research that's also coming out shows that there are some astronauts who don't appear to develop SANS, where there are others who have a moderate degree of it and some who have a more severe degree of it. So they're using that sort of information to try to understand the risks and try to understand who needs management or prevention of the development of SANS.
And how would the solutions be discovered or data collected during space flights that could help patients with similar conditions on Earth?
Well, I'm going to back that up to what can we do on Earth first. Right now, there are only so many ways that we can control the pressure of the spinal fluid. One of them is an operation to put in something called a shunt, which is a drainage system from the spinal fluid space in the brain, usually under the skin into the abdominal cavity. But that's sort of off the table. That's not something that could be done on astronauts either during space flight and is unlikely to be put into astronauts as a way to prevent it from happening. So then you have to ask the question, are there medications that could be used to try to treat the spinal fluid pressure? The one that's most commonly used on Earth has a lot of side effects and would not be very well tolerated by astronauts. I believe they've tried it a couple of times on astronauts, but it really has unpleasant side effects. But the way that we assess this in patients on Earth is that you have what's called an analog of zero gravity or microgravity. And that's actually done by having a person who volunteers for this research who's put into a bed and they're in head down tilt. So the head of the bed is about 6 degrees slanted downward, and they stay that way for 30 days. And research has shown that that can actually produce changes in the eye that look very much like SANS. So the research that I'll be participating in starting later this year is where we use that model and we use a novel medication that has been shown in some clinical trials of patients to reduce the spinal fluid pressure. It's actually called a GLP-1 inhibitor, so it's in the same class of medications as Ozempic or Wegovy, which you've heard about for management of diabetes or for weight loss, but one of them actually appears to reduce spinal fluid pressure. So we will have several groups of volunteers, some of whom will get this medication and some of whom won't, and we'll actually measure their spinal fluid pressure before the 30 days of head down tilt and then after the 30 days of head down tilt to see if it has an effect. There are other measures that we look at the same time. One of them is, do they develop the changes in the eye that we see in astronauts? And are there other ocular measures that can be seen? Once we understand how that works, then there are measures that could be used on the astronauts in space. In fact, because the main thing that's seen in astronauts is swelling of the back of the optic nerve, there are instruments that can actually measure this. These are used in ophthalmologic practice all of the time. They have one of those instruments on the International Space Station, and it's actually measuring the thickness of the lining of the eye at the back. And in SANS, overall, that becomes thicker. So they can use that as a way of seeing whether SANS is developing. If they were to use a medication on astronauts, assuming that it's been proven in human subjects, then they could look for prevention of the development of thickening of the optic disc in those astronauts as a way of monitoring it, or perhaps of indicating that they need to increase the dose.
Thank you. Why don't you show us some of the models here, and maybe that first one with what you were just last talking about.
Sure. So this is a model of the eye. I've taken a couple of the loose parts out of it. So the front of the eye is here. So the blue is the iris. That's the coloring of the eye. And when an ophthalmologist or a neurologist is looking in your eye with an ophthalmoscope, they're actually looking at the back of the eye, and they can see the blood vessels that are in there. They can see the tip of the optic nerve, and I'm going to turn it a little bit. So the optic nerve comes from the brain out to the eye, and this is just a little portion of it here. And from there, all of the nerves go to the lining of the eye, which is called the retina, like this. That optic nerve has a sheath around it. It's sort of like my sleeve around my wrist, and that sheath is in connection with the spinal fluid space inside the head. So if the pressure of the spinal fluid is elevated, that pressure is transmitted up the optic nerve sheath, and it can cause injury to the optic nerve, and it causes swelling of the optic nerve that we can actually see when we look in the eye or measure using the instruments. And the one instrument in particular is called OCT, which means optical coherence tomography of the eye. And that's a very quantitative way to assess the eye. There are some other changes to the eye that occur, but the swelling of the optic disc is the one that's of most concern.
Is there anything else you want to share?
So this is, of course, a model of the brain, and the eyes come here. I'm going to take parts of this out so that I can illustrate a little bit better. So the part of the skull that holds the eye is called the orbit. And if I turn this around, the optic nerve then emerges here and here and goes out this way to the orbit. And so all of this space is surrounded by spinal fluid. If we take a look at a cross-section of the brain, this is the interior of the brain, there's actually a little space here that holds spinal fluid, and that's called the ventricle. Spinal fluid is actually created in there. It then circulates through the brain and gets around the outside of the brain, and that's how the pressure of the spinal fluid in here can be transmitted to the optic nerve. Now, the pressure also goes down the base of the skull, and that's where the head connects to the upper part of the spine, and the spinal fluid actually goes all the way down the spine to the tip of the tailbone, and that's how a doctor can actually do a spinal tap or lumbar puncture to measure the pressure of the spinal fluid. And it's exactly the same as the spinal fluid pressure inside the head. We're just measuring it at a different location, but it's exactly the same spinal fluid pressure.
And then you have one last model over here.
I have one last model over here, and this is a model of the spine. And so when, and first of all, this is not actual size like this, but if you feel your back, the hard part of the spine is what you feel here. This is the tailbone down here, and your skin would be out over the front. So when we do a spinal tap, we're giving local anesthesia to the skin and to the tissues down here, and then this is often done without x-ray guidance, but sometimes can be done with x-ray guidance. You can then pass a needle between the bones, and you advance it very gradually until the tip of the needle is in the spinal fluid space, which is inside the spinal canal. And once the tip of the needle is in there, you can take this out, which keeps fluid from leaking, and you can attach a tubing to that that's attached to a pressure monitor, and that's how you can perform a continuous spinal fluid recording. You can also, of course, obtain a specimen of spinal fluid, and part of our research is looking into that as well, because the thought is that if something is changing in the brain, there may be changes to some of the proteins or other components that are in the spinal fluid that would tell us what's actually changing. Those are called biomarkers. And sometimes those biomarkers are used to say there's injury to the brain, or maybe in older patients there's Alzheimer's disease developing. But in this case, we're looking at biomarkers that would tell us Is there injury to certain parts of the brain or to certain what we call cellular mechanisms that are related to the development of SANS?
We have a question from Elise Takahama from the Seattle Times, and she is wondering how common SANS is in non-spaceflight travelers.
So in people on Earth, so first of all, on Earth, the disorder where the spinal fluid pressure is increased and causes swelling of the optic nerve, is called idiopathic intracranial hypertension, which is a way of saying that the pressure of the spinal fluid is elevated and we don't know why. Idiopathic means we don't know why. I have to admit, off the top of my head, I don't remember how many people have it, the percentage or what we call the prevalence. It's common enough that it's seen in almost every ophthalmology practice, and there are guidelines for how to diagnose and management. It tends to happen in younger people. It tends to happen a little bit more in women than in men. And on Earth, it's associated with very severe and debilitating headaches in association with the swelling of the optic nerve. And the swelling of the optic nerve can be so severe in idiopathic intracranial hypertension that it can cause loss of vision. People can go blind from idiopathic intracranial hypertension. And of course, the caution that I always say here is there's lots of other reasons to have bad headaches that are not idiopathic intracranial hypertension. So I wouldn't want people to think, I have bad headaches, therefore I must have intracranial hypertension. There have to be other signs and symptoms that go along with it. Most headaches are headaches such as migraine or chronic daily headache. In astronauts, approximately 80% come back with some finding or another that is associated with SANS, but only a much smaller percentage have the more severe forms of SANS.
And are there other potential risks specifically to the astronauts currently in space? This is a follow-up question that Elise has.
Sure. Well, there's lots of risks from being in space. Probably the one that changes the most is the radiation that's in space. So if we're here on planet Earth, the atmosphere protects us from a lot of the radiation. The astronauts who are on the International Space Station have a higher exposure to radiation from space because the atmosphere isn't protecting them. But the magnetic field of the Earth actually deflects or reroutes a lot of that radiation. But once you're in deep space, and getting out to the moon is in deep space, the amount of radiation goes up significantly. So it's not an immediate risk, but it's a long-term risk associated with astronauts. So the longer you are exposed to what are relatively low doses of radiation, then the higher the risk of injury to tissues, and there may be an association with accelerated cardiovascular disease or risk of cancer in the future. The other risks are those associated with the space flight itself, the launch, the reentry, and so forth. And of course, the Artemis space vehicle has been designed so it gets up there safely and comes back safely. The next big challenge will be the reentry of the Integrity capsule on Friday when they return to Earth. They enter the atmosphere at 25,000 miles an hour, and they have to slow down and then deploy the parachutes to land safely in the ocean after that.
What have you witnessed? I mean, you've been doing research since 2012. What have you witnessed over the years that has changed dramatically in your mind from your standpoint?
What I've seen is the research has become more sophisticated. The other thing that's changed is that the initial thoughts on what might be causing SANS have changed. There has been a lot of emphasis placed on zero gravity or microgravity, but the thing is, not all astronauts develop it. So that means that there must be some astronauts who are predisposed to be resilient or resistant to development of SANS, and others who are at greater risks. So there's research that's looking into blood biomarkers and certain nutritional things that can modify that. There's also some interest in understanding whether that long-term exposure to radiation could somehow be playing a role in the likelihood of developing SANS. So I think it started from a very simple analogy that SANS looks like intracranial hypertension to SANS may be the product of multiple exposures or effects of long-duration spaceflight. And all of that is good because that research uncovers changes that might help SANS, but may also help other risks that astronauts are exposed to.
And then we've had some astronauts in some of your studies. Tell us about the character that they have to just even participate as a volunteer in a study, for the betterment of space and lives.
I've had the pleasure of meeting a number of astronauts over time, and the first thing that I would say is all of them are incredibly committed to their mission, to their goal of getting into space. The next is that they're all very smart. You have to be smart, you have to be focused, you have to be dedicated to be an astronaut. And the next is that they are aware that there are risks of space flight, and because they really endorse the goal of long-duration missions to get to Mars or beyond, they participate in quite a bit of research, more research than the average human participates in, because they know that what's learned from their experience will help the goals of space flight move forward. And that's not only for NASA astronauts, but that's also for commercial astronauts. And we're entering the era of commercial spaceflight. There are a number of companies, I should say, that are going to be launching private space stations that will be used for research or for manufacturing or for other purposes. So there will be civilians, there will be commercial employees who are working on space stations in Earth, and they have the same exposure and risks of space flight as the astronauts do. So that research will help them as well.
Thank you. Any last comments before we wind it up?
Yeah, it's terrific fun to be able to participate in research with NASA and with Trish. I've not only met astronauts, but I've met incredibly bright researchers in all sorts of different fields from all over the country and around the world. And it's really, as a neurologist and as a researcher, it's fun for me to get to work with people who are that bright and that dedicated.
Thank you, Dr. Williams, and thank you everybody for joining us today.